So Jared, are you going to give me a signal?
You just typed in your good.
You're good to go, Alan.
Okay. Well, good afternoon. Thank you for joining us for the coronavirus pandemic and sustained peak loads for first responders virtual conference. We're focusing on promoting resilience and care for burnout. We recognize that first responders must respond to the concurrent economic, social, and medical crises confronting our society. They are the penetrating particle of the point of the sphere where these things come together. Their work ranges from security and law enforcement to rescue, medical interventions, and social work. It tests the limits of their capacities and is unrelenting. This dialogue addresses evidence-based strategies to promote first responders' resilience, and when these are not sufficient, treatment and wellness for their recovery. I'm Alan Lyles, your moderator for our virtual conference. The Henry A. Rosenberg Dialogue, our event today, is made possible by the generous support of the Henry and Ruth Blaustein Rosenberg Foundation and the University of Baltimore Foundation. A few organizational details before we begin. Our conference is being recorded, and afterwards, a link to the recording will be sent to all who registered. The times for today are approximate and may be affected by technology and the extent of the questions and answers involved. Please enter your questions using the Q&A feature at the bottom of your screen. We'll have time for a few live questions following our welcome and context comments from Dean Hartley and Mr. Thomas Carr. If your question is not answered live, we will do so after the event and share those answers with attendees. First, our discussants and short bios. Our welcome will be Dean Roger Hartley from the College of Public Affairs, and the context will be provided by Mr. Thomas Carr, Executive Director, the University of Baltimore Center for Drug Policy and Prevention, and Executive Director of the White House Office of National Drug Control Policy's Washington, Baltimore High Intensity Drug Trafficking Areas, HIDTA program. Our panel will be Dr. Lora Peppard and Mr. D. Kenneth Beyer. I'll give bios for them after Mr. Carr's comments. Mr. Carr has had a distinguished career in law enforcement. Prior to accepting his position with the Washington Baltimore HIDTA, Mr. Carr was a lieutenant colonel with the Maryland State Police and retired as chief of the Bureau of Drug Enforcement. He was first in his class at the Maryland State Police Academy in 1971 and has attended the FBI National Academy, the DEA Drug Commander School, and the Federal Executive Institute. As chairperson of the National HIDTA Program's Performance Management Process Committee, Mr. Carr has established metrics to measure the efficiency and effectiveness of drug control efforts in the fields of drug law enforcement, criminal intelligence, treatment, and prevention for the HIDTA program. HIDTA's performance management process system electronically collects outcome performance data from 34 HIDTAs and shares this information with Congress annually. The Office of National Drug Control Policy, ONDCP, awarded Mr. Carr the ONDCP Director's Award for his work in performance management. In response to the nation's opioid epidemic, Mr. Carr is working with ONDCP and other HIDTA programs on the overdose response strategy. This strategy has resulted in the creation of a public health, public safety partnership supported by the Centers for Disease Control and Prevention and the hiring of drug intelligence officers and public health analysts. It has led to an unprecedented sharing of opioid data among law enforcement and public health agencies. Mr. Carr spearheaded the development of the Overdose Detection and Mapping Application Program, ODMAP, a real-time overdose syndromic surveillance system used to identify spikes in fatal and non-fatal overdoses. ODMAP was cited in both Good Morning America and Roll Call newspaper for identifying a rise in overdoses during the coronavirus pandemic in May 2020. The Environmental Systems Research Institute, ESRI, an international supplier of geographic information system software, presented Mr. Carr and the ODMAP development team with its Special Achievement in GIS Award in 2017. Mr. Carr is the lead designer for HIDTA's Case Explorer system. Case Explorer is not only a case management system, but also an event and target deconfliction system in use nationwide by law enforcement agencies at all levels of government. Opioid overdoses investigations reports in Case Explorer are instantly reported to ODMAP, allowing analysts to explore links to drug trafficking organizations likely responsible for spikes in overdoses. As you can see, Mr. Carr is a leader who brings both creative thinking and action to this field. And now I would like to turn to Dean Hartley and Mr. Carr for our introductory comments.
Alan, thank you so much. On behalf of the entire University of Baltimore and our terrific College of Public Affairs, I want to welcome you on what is a beautiful spring day here in the city of Baltimore. Although I know many of you are joining us from our region, we are also aware that we have registrants from all over the place. And I hope that you're also experiencing the same type of day that we are. This is a most amazing event, and I wanted to begin by thanking you, Dr. Lyles, for the incredible energy that you have put over the years into the Henry Rosenberg and Blaustein chair that you have held. Part of the duties of that chair for everyone here has been Dr. Lyles, Alan, as I call him, amazing work over the years, putting together these dialogues that are on some of the most important and timely topics in the field of public policy, public health, criminal justice, and so many others. Alan, thank you so much. And I join you in also recognizing the incredible generosity of Henry Rosenberg and the foundation for assisting us with the opportunity to do this each year. Also to my colleague who is here today and will be following me in remarks, the work of Tom Carr and the Center for Drug Policy and Prevention and the work that he has done for so many years with his incredible team of HIDTA has really strengthened and provided safety to so many people across the state and region dealing with drug addiction, dealing with the scourge that drugs provide to our society. So I really appreciate your work and the work of your team, Tom. The College of Public Affairs, I'd be a terrible dean if I didn't say a few words about it, is a most amazing college. It is Maryland's only college completely dedicated to public service and improving people's lives. And this topic today is very much about improving people's lives. And it was my pleasure to see the topic presented and organized by you, Alan, because it's a perfect fit for what the University of Baltimore does and the college does in its mission. One piece of that mission is engagement. It's education for our students, but it's also education for our community. And it's making a real applied difference in public policy in the work of people in neighborhoods in Baltimore, in neighborhoods across the state. The college is made up of three impressive schools: the School of Public and International Affairs, the School of Health and Human Services, and our terrific School of Criminal Justice. And we have two centers, one represented very well here today, the Center for Drug Policy and Prevention, but also our William Donald Schaefer Center for Public Policy that does so much additional work in training, education in public policy and service, research in public policy and public service, but also a new division that is dedicated to student engagement for any student that wishes to go into the field of public policy or public service from any discipline at the University of Baltimore. Very proud of our centers, very proud of the work of our faculty, our resilient students, and our resilient staff. All together, we have been making a difference, and I think this dialogue is going to show how so. One more comment that I wanted to make, certainly as the pandemic has had an enormous impact on organizations, but more importantly, people all over this nation and world. I have to say thank you to everyone here and elsewhere that has put in the time and effort to help one another during this pandemic. And what makes this such a special dialogues is the work that you've done, Dr. Peppard, and you, Mr. Beyer, to make sure that our first responders are not experiencing burnout, that they are having assistance in the work that they do, and really that we focus on the resilience of the people who are helping people here and across our nation. So I am very eager to learn more today myself, because we are all in our own ways, in our own lives, in our own work, facing burnout at times and are dealing with so many stressors. So I will say that not only is this focused on first responders, but I think we can all learn a great deal from what we are about to hear today. So with that, I would like to turn it over and introduce my terrific colleague, Thomas Carr, who leads the Washington-Baltimore HIDTA, but also our Center for Drug Policy and Prevention. Tom?
Thank you, Dean Hartley, and Dr. Lyles, thank you for the kind remarks in the introduction, and welcome everyone. I'm glad to have you here today to talk a little bit about our center and some of the great work that Dr. Peppard and her staff are doing. So in the way of background, the Center for Drug Policy and Prevention really brings together policy experts and advocates and scholars who are dedicated to scientific research and exploring best practices for stopping the proliferation of drugs and violence in our communities. And the center focuses on applied research initiatives to reduce drug trafficking, to money laundering, firearms trafficking, drug-related violence, and gang activity, and pursues strategy really to advance public health approach to resolving the core problems of addiction. CDCP focuses its efforts in Maryland, the District of Columbia, Virginia, and West Virginia, and it includes, as mentioned, the Washington-Baltimore High Intensity Drug Trafficking Area Program, which is funded out of the Office of National Drug Control Policy. This is a federal grant program that provides resources to assist federal, state, local, and tribal agencies in coordinating efforts that address drug trafficking and drug misuse in specifically designated areas of the country. And I think it's important to keep in mind as we address this topic today that there are nearly 19,000 police agencies in the United States and almost 1 million police officers. These officers, along with emergency medical technicians and firefighters, are our first responders. They are the ones to first deal with all the legal, social, and medical crisis in our country. And in dealing with this crisis, our first responders, even in normal times, confront issues that continually test their resilience. But the COVID pandemic, coupled with the nation's opioid crisis, and let's not forget that there were over 81,000 drug overdoses in the United States between, in the last 12 months, I should say, ending in May 20th, the highest number of drug overdoses ever reported in the United States. This only exacerbated the conditions under which our first responders had to operate. My point is this, that first responders do what first responders do to protect us and protect all of us. It constantly strains their physical and well-being and mental well-being. That's why we're so concerned about their resilience. As you will learn in a few seconds from Dr. Peppard and from Kenneth Beyer, they have done some remarkable things to deal with this issue. Lora specifically, Dr. Peppard with CDP's serving as its director of the Division for Advancing Prevention and Treatment, or ADAPT, really went the extra mile to help our first responders become more resilient. So with that, Alan, I'll turn it back to you.
Thank you so much, Tom. And before we go to our panelists, a quick question for you. Based on the depth of your experience in law enforcement, going back now, I won't say how many decades, but going back for some time, do you see that the demands and the directions in which demands are being placed on frontline first responders as being different in kind and quality now than when you first entered law enforcement?
Well, thanks, Alan, but that was 1971. So yes, it's a lot different. There's much more demand on law enforcement today than there was in years past. Law enforcement is forced to deal with issues that when I started, they never had to deal with. We didn't have to worry in my day about drug overdoses. That was a rare thing. We certainly didn't have to worry about pandemics like the COVID-19 pandemic. Also, what's changed, I think, is the level of cooperation between law enforcement and public health and emergency medical services. Emergency medical services back in the 70s was a blooming thing. It just was coming around. Really, the first aid that was administered back in the 70s was administered mostly by either police or firemen. They didn't have EMTs to speak of in most places. Now EMTs it's a very professional organization, a very professional group of individuals, and I think this combination of police and fire and EMTs has really improved medical services and first responder services throughout the country. So yeah, I've seen a great change, and it's been for the positive.
Thank you, Tom. On just those points, and perhaps at another time in another conference, a year ago, I was in Portugal, and I had the opportunity to talk to João Goulão, who was a family practice physician who started to see the ravages of drug addiction in his communities and the families. And as a result of his efforts in integrating with public health, as you were talking about, Portugal completely reversed course in how it handled drug addiction. And it's more an integrated model, as you had talked about. So thank you for the forward-looking comments. Now,
thank you.
What I would like to do is to tell you a bit about our panelists and then turn it over first to Dr. Peppard and secondly to Mr. Beyer. Dr. Peppard, prior to her appointment at HIDTA, was associate professor at George Mason University and project director for several federally funded substance use and behavioral health prevention grants. Dr. Peppard is dedicated to translating evidence-based practices into integrated, sustained interventions in healthcare systems and communities. And in non-jargon technically, what that means is this is someone who is capable of taking science and applying it, not just leaving it in journal articles and books. And I think that's absolutely critical here. She has 15 years of clinical experience as a psychiatric nurse practitioner in emergency, inpatient, and outpatient settings. Dr. Peppard has developed innovative system-wide programs to address the unmet substance use and behavioral needs of the underserved, of the military, and serious mental illness populations. She also serves as a community, state, and national consultant on substance abuse and behavioral health intervention and integration models, and has authored several peer-reviewed publications for her work. This session that she will be discussing includes the recent Resilience Campaign 2021 and its 10 ways of building resilience. ADAPT has translated higher level concepts into concrete activities that can be immediately applied to build an individual's resilience. Dr. Peppard will now provide a synopsis of effective evidence-based strategies and ways of thinking about resilience. She offers specific, concrete activities participants in the webinar can take away and apply immediately. Dr. Peppard.
Thank you, Alan. I really appreciate being invited to talk with you all today. Resilience has been a topic that we have had an opportunity to dive into pretty intimately over the last few months with ADAPT. And when I reference ADAPT moving forward, I want to be very clear that I'm talking about an entire team. And I love the way that you set this up, Alan, and described us as translators. And that's what we really are. The whole division of ADAPT really serves to translate the evidence that's been generated through research, right? And replicated over and over again to develop a best practice, to translate that research into meaningful activities for the recipients and those that will be implementing those practices. And so today, what I am very excited to do with you all is to break down the concept of resilience a little bit more for you. Oftentimes it can be a little ambiguous, and I think people underestimate the value of truly understanding the multiple dimensions of resilience. And I can say with 100% certainty that it is extremely true that we as individuals can build our resilience, that it's definitely, there's something about it that we are born with, but you can absolutely grow it. And so that's why I'm excited to break it down for you a little today, and provide you some resources, but also maybe present you with a few different ways of thinking about it from organizational and community perspectives as well. Next slide. What I'd like to cover today are simply these three things. I'd like to define resilience for you. There are multiple definitions out there, multiple. And so I've chosen one that is generalizable and most likely relevant for all of you that might be attending today. And I'd like to characterize the concept of resilience a little for you today. I want to bring it to life. And I can't stress this enough. It is something I've taken on a new perspective around resilience over the last few years, and I'll share why with you in a few minutes, but it is extremely important, especially in today's time. And then I'll share with you some strategies to help you as individuals promote resilience, not only within yourselves, but within your organizations and communities. And we'll give you some specific ideas of what to do, at least at the individual level, that you can start today. Next slide. So I want to share with you when resilience first came to light for me as something I need to be thinking through as a professional in my daily work with individuals. And as Alan mentioned, I am a psychiatric nurse practitioner, licensed and trained as that. But I want to share one specific moment in my career, which was about 11 years ago when I was sitting in the Warrior Transition Unit, one of the Warrior Transition units here within our military. And I was asked to serve and treat post-traumatic stress disorder, generalized anxiety disorder, depression, bipolar disorder. We had a whole slew of mental health and substance use symptoms that we were addressing with soldiers that were returning from Iraq and Afghanistan primarily. And there was a moment in a treatment team meeting when we sat there, about 20 of us, squad leaders, first sergeants, master sergeants, the medical doctor, me as the psychiatric provider, several counselors, and we all sat there and we pondered two different soldiers. One soldier had visited Iraq, been deployed there, had encountered one intermittent explosive device, had one of his soldiers killed, both were officers, had one of his soldiers killed, and was immediately returned to our Warrior Transition Unit, came back to a very supportive family. But long story short, his marriage ended. He was never able to reintegrate into his family unit. His career progression suffered. He was medically boarded, which means he was discharged for medical reasons, which was PTSD. And his index event, which is what we called it, was that exposure to the intermittent explosive device and the trauma symptoms that had resulted from that. And despite our work with him, and I was primarily working with medications around the post-traumatic stress disorder symptoms, despite our work with him, he had several counselors involved and just immense support from his family. It was difficult. It was difficult, and his trajectory changed. changed after that event compared to the second soldier that we were discussing during that treatment team meeting, who had encountered more than likely up to 100 intermittent explosive devices, had multiple soldiers killed, did not have a family unit that he returned back to, but was actually returned back for back pain. And I was seeing him for literally just some generalized anxiety, mild to moderate depression. And he ended up getting medically boarded for the back injury, had an extremely successful career that he pursued, and reintegrated back into society very well. Two distinctly different scenarios. And the resilience factor came up during that treatment team meeting and really made an impression upon me, because we all said, I just wish we could bottle up whatever he had, whatever that soldier had that had multiple traumatic events he was exposed to, and somehow weathered it extremely well, extremely well. And I'll never forget that conversation about wanting to bottle it up and being able to dose it, give it, prescribe it, to everyone else within that warrior transition unit. And so I share that story with you because it's sometimes resilience is not tangible, but sometimes it is. And so my goal for you today is to really break down into concrete activities what some of those tangible things are that we can do to grow that resilience, but also to highlight the fact that there are multiple contributing variables to resilience, and it's important that we recognize that. When we look at a standard definition, you'll find many of them out there. Adapting well in the face of any variety of stressors, right, is what resilience essentially represents. And it's the way that an individual negotiates life and the passage, the journey through life. It can be very contextual, and it also, as we've mentioned, is multidimensional. So it's informed by multiple variables that are time sensitive, in many ways, and context sensitive. It can change. It can be variable across time and across the circumstance that you're in. And it involves thoughts, behaviors, and actions, as well as emotions. That, emotions are more of a reactive element, as are behaviors, but your thinking is something, usually a precursor to your emotions, behaviors, and your actions. And so I want us to really focus today on the fact that you can learn resilience, you can grow it, you can develop it, but maybe even in some ways more importantly, as an individual, these are things you can embrace, but as an organization, this is a responsibility that maybe you can assume, and maybe you can think through a little deeper. How are you promoting resilience in your employees? What type of environment are you creating that supports resilience within your employees? And then at the community level, how all the organizations intersect, where the funding streams are flowing. We'll talk about that in a few minutes, but essentially, how can you promote resilience within yourself, within your organization, and ultimately into your community? Next slide, please. What I've done for you here is highlight a few approaches to resilience, and what you see most commonly, and I'd be remiss if I didn't mention, resilience typically in many ways is talked about in relation to the environment, climate change, nature, and you noticed my picture on my title slide there that, when we think about that definition of growing in the face of adversity still and being able to adapt, the sweet little green plant that was able to figure out a way to continue to grow, even being segued between two rocks, right? So there are three different approaches that we think about with individual resilience, but the primary one that you see focused on for our individual resilience are internal attributes. And these are our personality or individual characteristics. And what I've done is I've drawn out some of them for you in these squares above the bullets. And so when we think about internal attributes, and my goal is to translate this for you, right? We think about our ability, our sense of control over our lives, over a situation, right? We think about our ability to persevere, how we manage our emotions, and our awareness of the dynamics occurring in any particular event, how optimistic we are, and that feeds into your perspective as well. Typically, you know, are you a half full or a half empty glass type of person? What is the self-efficacy measure that you typically center around? What is your sense of humor like, right? How's your ability to problem solve? And so these are several internal attributes that you'll see a lot of resilience building exercises focusing on. Another approach that is very important is from an environmental perspective, right? So what is surrounding you, right? What can be drawn and learned from the best to be found in your environment, whether that's within your family, within your school, and your community. And I think this particular one really feeds into that organizational resilience strategy. And then finally, the reality is it's a product of both. And so a good resilience-based strategy is going to incorporate both building and growing individual resilience, as well as that putting whatever shims you can in place within your environment to facilitate resilience as well. And we see a strong focus right now on something we call primordial interventions, primordial prevention, which is more of that environmental strategy prevention, where we are creating these nurturing and healthy environments for kids to grow up in and thrive in. And so, you know, we'll be attacking various pieces of that. And so I think that's a relevant example of the environmental approach. Next slide, please. So what you see here is a flyer of our first week of our resilience campaign. And I'm going to talk to you a little bit about that in a couple minutes. But these 10 items, these 10 ways of enhancing resilience really do hone in more so on the internal attribute approach, which we just discussed. And I've listed them all here. They come from the American Psychological Association. They developed a document called The Road to Resilience and listed 10 specific strategies, and they're all captured here. What you see to the right of that is our flyer that brings to life the first strategy on making connections. And so we titled that Connect with Others. And we have 4 specific domains with specific activities underneath them that we try to really translate for our target audience, which was the general population that we serve. We made this a big event, and within our resilience campaign, we offered it to everyone, because it was launched in December, you know, kind of in the thick of what we were all experiencing with COVID, and it was timely. And so we wanted to not really hone in on one specific population, but make it widely available, and then people can adapt it moving forward. So I'll share more about that in a second. But if you look at these 10 ways to enhance resilience, I think you're gonna see some of those internal attributes pop. So think about perspective, right? Think about self-efficacy. You know, my eyes are drawn to nurturing a positive view of yourself, right? Taking decisive actions, looking for opportunities for self-discovery, moving towards your goals. These are really great suggestions, right? But when we talk about translation, it's more than just understanding what's on the paper. It's more than just understanding the evidence, right? It's putting it into a format, making it meaningful to you so that you actually have an idea of how to apply it. And so that's what you're seeing reflected here on this Connect with Others flyer. That's strategy number 1, with very concrete activities and scheduling a coffee date with a close friend. That's under this Engage with People in Your Support Network. I did that the very first day we launched it. And let's go ahead to the next slide. Thank you. You'll see here on our tagline for the whole campaign was Do One, Share One. And so every week when we would actually push these out during our social media and email campaign versions of it, I would try myself to build my own individual resilience. And I just want to share with you guys, I even moved into this. I understand how important resilience is, but I even moved into this thinking, this is, I don't need to do this, right? But the reality is, wow, did it make a difference? Did it make a difference? And so just that very act, I reached out to a friend that I hadn't talked to in a long time, and we scheduled a virtual happy hour, and we just got together, and it wasn't coffee, but it was a sharing of experiences, and of sadness in many ways when talking about the things that she had encountered, over the COVID pandemic. And there was something beautiful about that conversation that we both left that hour rejuvenated. And so it just brought new meaning to me for the importance of, even though we think we might be resilient, there's always more to grow and build, because you never know what you're going to be weathering later on. What we did with this campaign coming out of ADAPT was, I've mentioned just this wonderful team that I have been blessed with here at ADAPT. Tom and I have been blessed with. And we have a clinical psychologist who's our assistant director, and she helped to really translate these 10 strategies into these actionable items. We also have a technical assistance project manager and a research analyst that helps support some of that grounding some of the strategies in literature and really researching, making sure that these are maybe the most appropriate ways to bring them to life. And over the course of the 10 weeks, we launched it in December, it concluded mid-February. We received a lot of feedback, guys, a lot of feedback. It reached hundreds of people. And to come back to this do one, share one tagline, a lot of the feedback we received was that people wanted to adopt, and they appreciated the tagline. They appreciated being encouraged to embrace one, right? Try it on yourself, but even more importantly, in some ways, share it. Continue to pay it forward and pass it on. So I think that's all I want to mention about this, other than I will have our website link at the end of the presentation. You all will receive a copy of that, I believe, through Alan, and you can click on that link, and all of our 10 weeks of strategies are available on that website, and you can feel free to disseminate your own resilience campaign. You can take just one. We had one site that wanted to, really was working with youth and wanted to put a crossword puzzle on the flip side of one of the flyers and use that. We have a community out in Missouri that is adopting the entire thing across multiple sectors. Teachers are pairing books on the topics for each week and reading those books on that particular concept to the kiddos. And then I'm talking about those resilient strategies. So it's been really neat to see it come to life across the nation after we disseminated it. And we do have it in an editable format now. So if you or your organization would like to adopt it in any way, my email will be on the end, and you can reach out to us. Next slide, please. I wanted to provide for you, beyond the APA 10 ways of enhancing resilience, a couple of other ideas, because you never know what's really going to resonate with you. And I'm telling you, there's a variety of options out there for you to choose from. I did include the PDF that I think Stanford does a really nice job with, the PDF for the APA. So I've got the link to that for you. You do have to be an APA member to access some of its other resources around resilience. So Stanford, this is a good starting point, this document. PositivePsychology.com has some really nice science-based resilience building activities. And I've provided some of those tools and exercises in that link there. Again, you're going to see some similarities and common denominators across many of them, but the idea is to, again, bring them to life into concrete activities you can apply, and you want ones that resonate with you. And then mindful.org, we're going to talk about growth mindsets, and mindful.org really does talk about remodeling the brain and how really engaging in some of these resilience building activities will assist in that process. And so I've provided a link there for you as well to access that site. Next slide, please. Now, I want to shift gears for a second. We've talked a lot about individual resilience and how to build that. And I shared those 10 strategies from APA. I shared how we've brought to life one of those with some concrete activities. But have you ever asked yourself, how resilient is my organization? And I pause because, I even asked myself that. How resilient is my division? How resilient is ADAPT? Because we sure are under a lot of stress right now. There is a lot to do providing training and technical assistance. How am I putting enough shims in place, enough of a buffer that we can weather the storm? And I don't know that enough organizations think through this. They're very forward thinking if they are, but I wanted to break this down a little bit for you as well, because you can do this. You can do this. When we think about the focus for organizational resilience, it absolutely encompasses individual resilience strategies and providing opportunities for individuals to build their own resilience through those activities. But it also includes analysis of how resilient are your processes and your culture, right, that you've created. How is your culture informing those norms, those values, beliefs within your organization? How is that informing your ability to weather any storm? And this is particularly relevant for law enforcement and first responders, right, during this time and during any time. And I'll tell you why. Just inherent in that particular population is unpredictability. It's unpredictability. And just living with that variable of unpredictability in and of itself is a stressor. And so you always want to make sure there's a strong buffer, particularly within those organizations that aren't necessarily as scripted, that your resilience factor is extremely high. There is a book called Resilience Factor that I just learned about, but you'll hear me use that phrase moving forward. All right, the more strategies that you can develop as an organization for your employees, within your processes, within your culture that relate to resilience, the greater the likelihood you're going to be able to successfully navigate and weather what comes your way, right? It increases the buffer. But if you asked me today, or if I asked you, what resilience strategies have you built into your organization? That's ambiguous, right? You can't necessarily draw that down unless you're extremely aware of resilience literature and it's been translated for you, right? And so I've provided a couple things we're going to talk through, but I really wanted to, we don't have enough time today to tease it out at the micro level, which I would love to do for you. But I want to introduce you just to this concept of organizational resilience and give you some key considerations. Risk management in and of itself provides a really good framework. If you have a risk management process in place, it's a good framework to be able to be proactive and manage that unpredictable element, right? The unexpected. So that's a starting point. Job design. Thinking about the different roles within your organization. What are the demands on each particular role, right? How much control does each particular role have in its environment, in its tasks and responsibilities? What motivators or rewards are built into that particular role? Another thing that you can think about, a key consideration, is the culture and the structure. And I lifted a quote from a really great article, and I'll provide the reference list for anyone who is interested, but I have it up here. If you look at the top right-hand side, this relates to culture and structure. A resilient organization effectively aligns its strategy, operations, management systems, governance structure, and decision support capabilities so that it can expose or uncover and adjust to continually changing risks, just like first responders and law enforcement are engaged in, endure disruptions to its primary earnings drivers, and create advantages. It's all about really creating an advantage, building that buffer. All right, another variable to consider is leadership. Bureaucratic style maybe is not as favorable, but we know that we have evidence, engaging, supportive styles within leadership influence resilience in employees. And I can tell you hands down that my own boss, Tom Carr, that you just heard from, he is a leader that does really create that type of culture and environment that is engaging and that is extremely supportive of things like ADAPT, going after the resilience campaign, of us weathering and trying to navigate the technical assistance demands that we're encountering. And then finally, the systemic or the external environment. And I think this is really key and applicable to first responders and law enforcement as well. Having social and institutional support at every level. And it takes an analysis, you know, it'll take a survey, it'll take a closer look, a deeper dive at every level to determine, is that support adequate, right? And that you can't just do that as a leader. You have to engage the participants at that level. Do you feel supported, right? What else could I do to build into your day, right? To build into your locus of control, right? Is there anything that I could do or change, you know, within your environment or your role to enhance that, right? And that would be one way of growing resilience. And then promoting opportunities and networks of successful relationships. That's extremely important. Having roles that are isolated and not able to process things, especially with first responders and law enforcement, not able to process and share what they've just experienced together, right? And work through it. Without that, you're going to have a less resilient organization. Next slide, please. And the only thing I want to say about this is the population, so first responders and law enforcement are a special population, just like youth are a special population, just like teachers and parents. And you can translate those 10 ways of building resilience a million different ways. What I want to hone in here on is, in order to translate it effectively, right? What really needs to happen is that the language needs to be relatable to that discipline, to that special population, right? And Ken and I have talked about getting together at some point after this and really maybe conducting a focus group with some of his participants and his organization to make sure that the language, when we translate this campaign for law enforcement first responders, that it's relatable to them, right? Because locus of control means nothing, I bet, to them, right? And so some of the fancy language that might be used within the concept when it's studied, right, might mean nothing to the actual recipient of the concept. So relatable in language, relatable in experience. And so when we talk about experience, making sure the activities are actually relevant and relatable to the recipient. So instead of maybe scheduling a coffee, right, with a close friend, maybe it's hanging out 30 minutes after shift and, I don't know, sharing a piece of chocolate cake or whatever makes sense for that organization, walking to the parking lot together, right? And being intentional about spending some time in processing what just happened that day together with your partner, your law enforcement partner or the first responder. So, and see, you can even tell, I don't live in law enforcement. And so this is something that we're going to be, Tom has to educate me all the time on what that language is and kind of what would be familiar, because I come from a nursing background. And so that my language is completely different. We're a little more touchy-feely, and, you know, we kind of really appreciate the social bonding, and social bonding for law enforcement is very different. And so I think I've just demonstrated, without even meaning to, my lack of knowledge, right, in how to make that relatable for law enforcement. And that's why it's so important to conduct these focus groups with them when translating these concepts. And then breaking down the concept into digestible pieces. So it can be overwhelming. I mean, we've talked about it's multidimensional, and it can be sophisticated to a lot of people. So breaking it down into bite-sized pieces that make sense. and enhancing it through organizational support. Next slide. So the only thing I want to draw out here for you is that if you successfully engage in resilience interventions for yourself and for your organization, right, that you really are facilitating a growth mindset. And there, you have heard this term come out in great effect over the last 5 years or so, the growth mindset phrase, right? I see it in my kids. I've got this big life journal that I do with them. They think about their purpose in life, you know, and it just kind of breaks down different steps for them to kind of promote their locus of control by increasing their awareness, right? Their awareness of these things. And that's what you're doing with resilience intervention. So I just wanted to weight that a little bit more for you, weight the importance of it through bringing that to life. And then this is a particular scale. Let's say you decide, you know, Lora, you had an impact. I think I want to go measure the baseline of resilience at my organization right now in my employees, right? Well, hot dog, guess what? Here's a tool. It's called the CD risk. You can do it. You can do it. Why would you not go get a baseline? This is available to you. It's 25 item scale, and I believe it's scored from 0 to 100, right? And so we see typically that, you know, any average Joe off the street, right, might score within like an 80, 85 range, maybe even 90. And then the higher the score, the higher your resilience factor. And then, you know, those in outpatient mental health settings, right, that are struggling with maybe some comorbid behavioral health conditions might be down in the lower 70s. And it's a spectrum, but here's a tool that you can use towards that. And I provide the link for you there. So Tom, how about it? I think we should do this with the Washington Baltimore HIDTA. All right, next slide, please. And then finally, I wanted to mention community resilience. So we at ADAPT and Washington Baltimore HIDTA, we've thought through, you know, if we wanted to measure and map in some type of way the prevention programming through some type of visual of a net in that community, what does the prevention net look like related to preventing onset of substance use, identifying and re-stratifying that use, and then mitigating further harm from more severe use, right? And what evidence-based strategies are employed already? Where are we deficient? What sectors still need to be engaged? We were calling that a prevention assessment map, and we've piloted that with a few communities, and it's been effective. We're going to make some tweaks. But I stumbled upon this particular tool, which I'll admit is, unless you're an academic, which I believe some of you might be, and you're kind of used to this language and applying even some of these like coefficients and analysis, it might seem a little far off. But I put this on here because I just want to draw your attention to it conceptually. This is available out there. We're starting as a nation to think through, how can you measure resilience in a community? And what I loved about this one was that it was focused on the substance abuse continuum of care. And that's neat. That's neat. It's got a specific focus, and it's not just on a community's resilience for natural disasters, which we see some of the other scales that have already been developed focused on. So it's a starting point. This one looks like published in 2016, and moving forward, I'm sure there will be other derivatives, maybe even more user-friendly derivatives. But Tom and I talked about, and the deputy director of HIDTA and I talked about, what would it be like if we piloted this with Washington Baltimore HIDTA and got some sense of resilience in this particular domain of substance abuse in our communities. And then next slide. So our tagline for the resilience campaign was do one, share one. I'm adding a third challenge to all of you. Build one. So if you work within an organization where you have influence, right, to be able to build resilience within that organization, don't be shy. Do one for yourself, build your own resilience, share it with many others and many other individuals within your organization, but then build a culture of resilience and a culture of whole health within your organization. Next slide. Thank you for the opportunity to talk to you about resilience today. I'm available via this email, but also our ADAPT website is on this link, and I have put hyperlinks within this PDF that Alan will disseminate. So if you want any of those resources, they're available.
Thank you, Dr. Peppard. I want to take time for a short question that's here that might relate to Mr. Carr and you. And that is, as we transition to Mr. Beyer and the work that his center does for law enforcement and first responders, we're considering now how you identify, how you assess, and then how do you grow resilience? My question to you and to Mr. Carr, what happens if someone breaks, so to speak? What happens to the person who is overwhelmed and that these have been insufficient, and then they receive care? How does the organization view that as an outcome? Are they someone who could be reintegrated? Or is it something that's understood in the nature of the culture? Or is this still something that's growing and learning to accommodate a different view? And it's not binary. You're either unbreakable or you've been broken. What I'm hearing is the resilience is taking the public health approach and using evidence. Mr. Carr, the public health approach integrated with the data and the analytics that you were talking about. How does the culture accommodate this? Because I'd like to then introduce Mr. Beyer, and he can talk about how he steps in at that point.
Laura, do you want to go or do you want me to?
Go ahead, Tom. I have some follow-up thoughts.
Okay. Well, I think that what we're talking about is organizational change. And it requires a change in the culture. Now, when I started off, you were broken or you were unbroken. And what they did with the broken ones, they got rid of them. There was nothing about employee assistance plans. There's nothing like what Kenneth Beyer has that would help an officer or a medic or a fireman who had been suffering from stress. There was nothing there to help them deal with it. So oftentimes they bottled it up, and it came out later on on their families, and it affected their families. So they carried as they say, they carried their work home. And what you try not to do is take your work home with you. You try when you leave the office, leave the work there, like a lot of white collar office workers do or are able to do. But unfortunately, with police officers, the things they see, or medics, the things they see and the things they have to touch and the things they smell lingers on with them. I still remember the first body I saw that was run over by a tractor trailer. I remember, the first person I saw wasn't really a person. The first body I saw that had been decomposed for 6 months. You don't forget those types of things. You learn how to deal with it. Then we didn't have the types of systems that are present today to help you deal with those type things. But I'm glad to say that the culture is changing as younger folks have moved through the organization, and the culture has changed, and that change has been, for the most part, I think, very positive. Laura?
Thanks, Tom.
Yeah, the only thing I might add to that, because I think that's a really important point, that what we see today in terms of reintegration of those that may have experienced challenges, right? And symptomatology related to those challenges, right? We see many organizations and systems developing pathways, right, to reintegrate those folks. And so there's a greater appreciation for the value of doing that and less stigma associated with that. One thing I do just want to mention, the clinician in me just wants to mention that when you I think it's really important to define broken. So that's going to be a relative term, right? And so they may have been hospitalized, right, for symptoms that they are experiencing. And when we think about levels of functioning, it's an informing variable and a very important one. So just as I mentioned with those two soldiers at the beginning, right, there will be some that can be hospitalized and fully reintegrate without much difficulty. And there will be others that, for whatever reason, you know, those multiple variables informing the success of that, for whatever reason, whether it's organic, you know, in nature, whether it is environmental or social in nature. The environmental and the social, we tend to be able to grow. And the internal attributes I mentioned, we can grow, but the organic piece of it, we couldn't necessarily address as well. You know, that's where medications come in, that biochemical component. So I do think that's an important variable to consider, that organizational cultures absolutely are much more accommodating now and embrace the value of integrating those who may have been broken. We see that time and time again with this acknowledgement of depression, with this acknowledgement and embracing treating depression, treating trauma as part of whole health, right? A whole health approach. So that piece is very important, but everyone's story will look a little bit different. And so I just wanted to add that extra layer, that there's the clinical consideration as well. You know, how much has the episode or whatever they encountered, maybe it's a cumulative effect, but that one break, how much has it impacted their ability to function in multiple domains?
Thank you so much. That gives a perfect transition to our next discussant. Mr. Ken Beyer is a firefighter of a couple of decades, an EMT. He has extensive experience. His professional experiences prior to Harbor of Grace include management with residential and ambulatory care for substance abuse, being an experienced firefighter in EMT, as I said, and a successful businessman who has started multiple businesses. These experiences uniquely qualify Mr. Beyer to identify first responders' need for stress care, substance abuse, and wellness care. His insights, motivation, and tenacity led to the successful creation and development of this growing care organization, Harbor of Grace. He'll discuss with us now his experiences with first having the insight, then having the early initiative to create, and now to expand, and where he sees this going in the future. Ken, it's all yours.
Hi, thank you for having me today. Dr. Peppard, I really enjoyed your presentation, and I like the fact that you highlighted the special needs for this population. The other thing I really liked is how the relatable language and experience aspect of it. This population is really different to treat, just like an adolescent program would be, or another specialty group. So, you know, I identified the needs for first responders early on. I'm one of those firefighters that was born out of 9/11. So if you recall, our president asked on that horrible day, ask Americans to volunteer, do something in your community. So my son and I became volunteer firefighters to begin with. And then after a period of being a volunteer, I decided to go work for a municipality part-time. And I did that for many years up until February of this past year. One of the things that I noticed right away is I recognized immediately the lack of resources for first responders. There just wasn't any resources available that really understood the population. They lacked mental health services. They couldn't treat PTSD properly or workplace trauma. As Mr. Carr pointed out, you know, first responders see things that a human being really shouldn't see. And I can remember my first experience too. On my very first call was riding on a heavy rescue, And it was an automobile accident where a motorcycle slid underneath a tractor trailer, and the young man and woman on the motorcycle were decapitated. And the captain that was with me at the time threw me a bag and said, "Go look for it." And I said, "What?" I was new. "Go look for the head. It's around here somewhere." And I've never forgot the insensitivity and the way that he was so hardened by that. It meant nothing to him. And fortunately, I wasn't the one that retrieved it. But I'll tell you, I was there and I saw the bag, and I just couldn't stop thinking, wow, there's somebody's head in that bag. And that happened many, many times over the years in different ways, either by accidents or drownings. I was on a regional dive team for 10 years, and they said it was a rescue dive team, but I'd never seen a rescue when you're diving, because you're usually an hour. The call comes out an hour after the event, and it's always a recovery, so it's not a rescue. So seeing all these things, the one thing that I brought to the table that the other folks didn't have is I had been sober for about 7 years personally. So I had worked a program of recovery, and I was able to cope with those things a little bit differently than people that needed mental health treatment. So I recognized early on in the fire service that these folks weren't getting help for addiction-related issues. And it's not only alcohol. The first responder world has problems with gambling addiction, sex addiction. Many of them have severe financial problems. The divorce rates are very abnormally high. When you were talking about broken, when they come into this level of care, they are broke and broken. And one of our slogans, and it's we just use it loosely around here, we fix broken blue. And we try to look spiritually at this person, medically, psychiatrically, emotionally. We try to really look at every facet of this individual and really peel the onion to see what's driving the behavior. First responders in general, and I'm sure Mr. Carr would agree with this, we always say that there's something wrong with somebody who runs into a building when people are shooting at you. That person's not normal. And they say the same thing about a firefighter. Everybody's running out of a burning building and the firefighter's running in it. There's something wrong with that guy or gal that's doing that. And so it takes a kind of an unusual personality. I don't like to use the term adrenaline junkie, but many of us are. And so this population is really complicated to deal with. They're very insecure. In our level of care here, you identify the problem of what they need. And I began working as a peer before we opened up Harbor of Grace, and I was referring people to other treatment centers for their addiction problem, but it really didn't address all the underlying issues. And so I would coordinate treatment options with various providers, but the providers didn't understand this unique population. And sometimes it was a hit or miss experience, but I realized that these mental health issues weren't being addressed, and the job-related stressors weren't being identified and treated, and the peer support issues weren't addressed. So, one of the things I did is to create or to meet that need was, it was a very bold move, but I started a center with a bold vision that was unmatched by any other provider. And I put pencil to paper and said, what is the ideal treatment environment for these folks? And I realized if trust was going to be established, unprecedented steps had to be taken to achieve that vision. And they included many things like, I think we're one of the few providers in the country that all the staff in our first responder program are either an active first responder or a retired first responder. And that includes our clinical staff, our LCSWs, our counselors, our therapists. They are all first responders themselves. And What this does is it promotes immediate trust from a population who generally only trust their own. It eliminates a patient from feeling like their own issues are not understood. We have someone that works here who is a retired SWAT medic from Baltimore City, and Alan Lyles knows him, and he likes to say, I don't know how many dead babies you've held, but I've held my share of them, and I'd be just as happy if I was never handed another one in my life. And when you say that to a first responder when they come into treatment, they understand you know. So that establishes that automatic trust in the provider. So the relatable language is, we use it here as well. First responders talk different to first responders, as Mr. Carr knows, being a former trooper. It's a very colorful vocabulary, and we tend to be very brutally honest with each other, and we do that in a treatment environment as well. We call them out if we need to call them out. So, you know, that really accelerates the relationship, and then you can really get to the meat and potatoes of what they need. And it's the trust is established almost immediately. I have found, after doing this for 20 some years with first responders, that, you know, they don't trust very many people, but when you earn their trust, they can really settle in and start working on their issues. As long as they know it's a safe environment, they know it's not going to go anywhere. They know this information is not going to go back to their agency. And as Mr. Carr said, there's been a lot of changes since 1971. There really has, but you know, they didn't have EAPs then, and now every agency has an EAP just about. However, there's a lot of problems with EAPs today that we find, and most municipalities are, you know, expeditiously putting these EAPs together, and that person that's in crisis may call a 1-800 number and get somebody in Texas that will try to get you an appointment in 2 weeks. Well, it's too late. That officer or that first responder could commit suicide by then. And that's the biggest issue we face today is in many cases, suicide exceeds line of duty death. And one of our jobs as providers is to identify that quickly and say, wow, we got to get that person in here quickly because we want to eliminate that. We also promote the need for peer support, which is the cornerstone of success once they get out the continuum of care model. You know, as they reintegrate into the first responder community, it gives them a sense of belonging. We have established 3 or 4 different first responder meetings, one in Annapolis, Baltimore County, Havre de Grace, and we are in the process of putting one together in Lancaster City for their PD, and in DC as well. And we're trying to make a meeting place that's safe for first responders to go to, where they can vent. Many of them have alcohol or addiction problems, gambling problems. It could be a lot of different problems, especially with as complicated and challenging the times are now for police departments. When we turn the TV on and we hear about defunding and anti-police and then the pandemic, and there's so much stress that these folks are under, and we are seeing an uptick, a big uptick in it when they're coming in here. We're not just dealing with the addiction. Today, for instance, we got 4 officers in today, 2 from Georgia, 1 from Maine, and 1 from Calvert County, Maryland. And 3 of them are what we call, they came in hot. They came in a lot of stress. One was a suicidal ideation, drinking, you know, a lot of different reasons they come in, and we try to get them in as quickly as we can. So the other thing we've done to meet that need is I believe we're probably one of the only centers that have focused on other services that include a 24-hour rapid response team. On our staff of first responders, we have 5 of us that are CISM trained, critical incident stress management trained. I'm an interventionist, and 2 of the gentlemen that are retired from one from Baltimore County Police Department, the other one from NYPD. They're hostage negotiators, and this other gentleman I mentioned earlier from Baltimore City has been sober a lot of years, and he's able to go out and help pick up people in crisis. And with this 24-hour rapid response team within a 300-mile radius, we send one of us out in a matter of minutes to go pick that individual up at no charge to the department or the individual. And our goal is to get that person out of harm's way immediately. And we respond after mass casualty incidents, things like that. The other things we do to help is we assist quite a few police academies with training. In many cases, in the last couple of weeks of their academy classes, they start talking about wellness and resiliency, and we do lectures on overall wellness, on why not to self-medicate, and the dangers of self-medicating and binge drinking. I just did one for Baltimore County Police Department on Monday at their academy. So, these are the kind of tools that we're using today to deal with policing in 2021. Our facility, we're very fortunate that we have a subacute detox. Our psychiatrist is full-time and he's triple boarded. We have a psychiatric nurse practitioner, a medical nurse practitioner, 15 registered nurses that are ER trained. We have 2 counselor aides. Many of those are first responders. They help with patient community and just staying with the guys and gals and keeping them grounded. Our admissions team is 24 hours a day. We admit people 24 hours a day. We have a therapist that's designated for trauma work for first responders, and she's trained in ER and brain spotting therapy. So we're trying to think outside the box in any way we can, and as these things evolve and change, we're trying to meet that need. And we just opened up our National Law Enforcement Wellness Center that is exclusive to our first responder program. We're training police departments. Every week we have a different department here that's training for peer support, helping them set up peer support teams. Yesterday, I was in Lancaster City, and we're going to help them. They have 2 mobile crisis therapists they've just hired, and we're going to bring them down here. We have 3 mobile crisis LCSWs here that worked at Baltimore County Police Department, and they're going to train them how to get theirs up and running, because in Lancaster, they don't put that therapist in the police car. Well, in Baltimore County, they do, and they have been doing that for quite a while. And so we're going to help train them. We do that free of charge, by the way. We're a private facility with a very strong not-for-profit conscience. And as a private facility, we gave over $600,000 away last year to officers and first responders that were in need, whose insurance did not cover treatment. And we were always going to do the right thing and keep that person for as long as we needed to, until they got to the lower level of care, until they were ready for the lower level of care. And I came from the not-for-profit, nonprofit world, the facility that I worked at for the better part of 15 years after I personally got sober. So my mindset is the not-for-profit world, and I've been able to manage that very, very well as a private facility.
Thank you, Ken. I have found it astonishing to watch the growth. First the idea and then the growth. In 6 years, if you want to put some numbers on it, how much has Harbor of Grace grown? And if you were to talk about the footprint of it, how do you go about making some of this a reality? If we could do a sort of a parallel idea with Dr. Peppard, what she was talking about with taking research and translating it so you can apply it and use it. Well, you have an idea, but I think for many people, the idea is too big. It's too intimidating. How do you actually make that occur, and in such a short time, 6 years?
Well, you need a lot of luck. I can tell you that. Luck always helps. We started out with one building and 4 employees, and today we have 88 employees in 8 buildings. I was walking on our little campus last week, and a new employee walked past me and said, "Do you know where you're going?" I didn't know them. And I said to her, "I do." And she says, "Good." And, I didn't say anything because she's doing her job. I'm supposed to be giving to the lecture if I'm a patient. And I just laughed, and I thought, wow, we've really grown, when, now the next day I introduced myself to her. But, so it's been we're just trying to meet the need, Alan. We just show up, and I've been very fortunate that the right people have walked into our lives at the right time. And that started with when we were looking for a psychiatrist. It's very difficult to get a psychiatrist. I mean, they're just not available. And we not only got the right psychiatrist, but we got one that was willing to work at a startup treatment center. And he liked my vision, and he liked what we're doing here. He's grown tremendously. One of the first things we did is I recognized that he didn't have a lot of experience with first responders. So I said to him, I said, "Dr. Lerner, I'm going to get the chief's car, and you and I are going to work on weekends, and we're going to ride around Harford County, monitor the radio, and wherever there's a hot spot, or if there's a call, cardiac arrest, or shooting, or whatever the case may be, you and I are going to respond to that. And our patient isn't going to be the patient that called 911. Our patient is going to be the first responder. I want you to see what the first responders are going through." Well, the first night I learned that Dr. Lerner is a closet junkie for action, and he really liked it. And we got a lot of interesting calls, and he was just absolutely blindsided by how intense it is just driving to the scene of an accident, or you're in the rain and you're going to a working fire, or a cardiac arrest. And he got to see everything. And we did that repeatedly, and he really got to learn firsthand about what we do. That's helped him tremendously on how to treat our patients. Mm-hmm. Growth, Alan, has been, we just met the need as it came, and the resources were there. And then as we continue to grow, we said, well, let's add this and let's add that. Let's go ahead and get our license for withdrawal management, and let's go ahead and do state-of-the-art withdrawal management. Now, I'm not aware of any treatment center that flows fluids when a patient is dehydrated. Well, I said, well, that's ridiculous. I mean, we're all first responders and we hang IVs in a medic unit. Why can't we do that here? And we did, and we got our nurses. We only hire nurses that can do that. So that's why we hired emergency room nurses. And I don't think any of the treatment centers are even doing that. Mm-hmm. There's just a lot of little things, I think, that are that define us as being different. And, it's always about patient care. One of the things I've always tried to do is, what do we need to do to make the treatment experience a better experience for that person? And just by doing that every day and having the right people step into our lives, it takes a lot of good people to run this place. And I recognize that. And I thank them on a daily basis. This is a team effort. And I'm amazed at where we are today, and 88 people working here and 8 buildings. And I'm not looking to grow. I just want to continue doing what we're doing. We have 44 residential beds and 7 acute beds for our medical wing. And, we stay 90% full all the time. Sometimes it's 100%.
Well, if I could connect this to what Mr. Carr and Dr. Peppard had said, the short form for culture to me, as I heard someone describe, culture is who you hire. And I think I've seen that where you are. So what I'd like to do before I leave it open for Tom and Lora and you to interact or clarify or ask a question of one another is to talk about a latent aspect, Ken. I remember as you were starting to do this, we walked through an apartment complex in which you had 1 or 2 rooms finished off that you were building. So that would be the secure residence for the treatment center that you were going to build. And I said to you, wow, this looks like at least a 4-star out of 5-star residence. And you said, well, that's because we want them to know that we respect who they are and they're here to treat what their disease is. If you want to talk a little bit about how that idea of respect in the culture and the space itself, how you try to inculcate a different vision. It's almost like listening to some of the strategies that Dr. Peppard had mentioned. You know, I could start to see that in how you have the gym and the way in which staff interact too. It's mutual respect. You mentioned you call people on things, but it's done from a perspective of what's good for your growth. If you would say a little bit about that, and then I'd like to open it up for Tom and Laura and you. Anything that you'd want to ask each other or make sure people know before we wrap up.
One of the things in my background that really helped me here was my affiliation with Father Joseph Martin at Father Martin's Ashley. And he always thought that, you know, alcoholics were at, when they come in for treatment, at their lowest point of their life, their self-esteem was so damaged, and that, you know, you should have a very nice facility for them to feel like they're worth it. So the building that you were talking about, the residential building, previously had been a Section 8 building, and I purchased it and started to design, you know, how I could make this into look like a 5-star place, and with triple crown molding and the, you know, the best woodworking you could get, and you know, granite countertops, even things down to the mattresses that we get. We get the most expensive pillow top. We don't go buy bulk and buy volume and say, let's get something for $200. We get a $1,000 double pillow top, and then people feel comfortable. And that's always been my philosophy. And remember when I finished that building, I took my wife over there to show it off to her. And I said, look at this, isn't this great? She was quiet. And I said, what's wrong? She says, I have Formica at home and you have granite here. You know, I said, I'm sorry. She said, you think it's alcoholics and you do your family. That way, but that's true. So we still have Formica at home. But I just try to go the extra mile. As Father Martin used to say when someone asked him, how far do you go to help an alcoholic? And his answer was, you go as far as you can humanly go, and then you take one more step. And I think every day here, all 88 people here take one more step. And if you live your life like that, it's easy. It's really easy. So patient care is our #1 priority here. And we don't just say that, we do it every day. I'm the only person that gets the patient surveys, and being a CARF accredited facility, we have to get a survey from every patient upon discharge. I don't allow any of my help to see it first. I want to see it. I take constructive criticism very well. And then I share all the things that are good with the staff, and I throw the bouquets where they need to go, because it takes a lot of people to run this. So that's my philosophy on quality. And you know, if you show your patient community that you respect them, and you show them that you're willing to take go as far as you could humanly go, then take one more step. It really sets the stage for them to focus on recovery. And this is a facility that gives people their soul back. And then, by the way, they get sober, and then we can deal with their mental health and their depression and anxiety and PTSD. But they get their soul back. I'm very blessed to be given an opportunity to be in a position where we can affect so many lives, especially first responders that need it so much. That's our philosophy. That's worked here.
Thank you, Ken. And for our attendees, I would like to point out that we've been fortunate for each of our speakers today, from Mr. Carr to Dr. Peppard and Mr. Beyer, that you have world-class people who have expertise, they're willing to share it, and they have the most well-developed sense of integrity and commitment to a life of meaning and values. I'm hoping that that's what you'll be taking away from this, as well as the particulars for following up on things that you can do to develop resilience, things you can do when first responders are overwhelmed. Having said that, and before we wrap up, I'd like to ask if Mr. Carr and Dr. Peppard and Mr. Beyer, if there's anything you would like to share among yourselves, to each other, or for our audience.
Let me speak first. I just would like to say I think the work that Mr. Beyer, Kenneth, is doing is just outstanding. He's right. There was never anything like his organization prior to his organization. And his approach of sort of nothing about me without me, and having the understanding the relationship between, in his case, being the treatment provider and the person that's being treated, and building that trust is so important. Gaining the respect of each other is the way, and holding hands then through the treatment process is the way to go. And it's difficult, you know. It's those suffering from substance abuse and mental health problems, as Lora can speak to firsthand. They're difficult to deal with. The answers just don't jump out at you, and it takes time, and it takes patience, and it takes a special person like Kenneth and the people he has employed, and Dr. Peppard and the work she does to deal with this population.
Thank you, Tom.
So thank you, Ellen, for allowing me to participate. I thought I was just going to be an introducer, not the subject matter of the
We got
event.
lucky. We got lucky.
Yeah.
Lora, any concluding comments?
The only thing that I might mention is, as I was sitting listening to Ken share the full story, because we've talked before this a little bit, right? I was thinking to myself, wow, what a growth mindset he has already, right? So he's really approaching just the development of that. You heard him say, even at the end, you know, he listens and he takes feedback and he incorporates it where it makes sense. And he's this lifelong learner and embraces, you know, what's out there and available, right? Any new innovations related to that. So as I was listening to that, I thought, you know, his perspective, right, as a leader in that organization is already spot on. It's already spot on. What would be really neat, and Ken, I hope your ears are burning. I see you just got connected again. We're saying wonderful things about you.
Oh, I missed that. Yeah, no, I just had to change locations. I lost power at that place.
I have it recorded, Ken.
So that perspective is very important. But the other thing I wanted to mention is that he was talking about the population that he serves. And this is one insight that just occurred in a conversation I had with a lady who runs health services for a jail, right, today. And we were talking about resilience in this presentation today, and it dawned on us, and I don't know why it took this long to dawn on us, but we asked ourselves, why are we not conducting resilience movements in these types of organizations, in the jails, where you've got inmates who have these histories of traumas? You know, 70% in many cases of inmates have a trauma history. So you've got these vulnerable and at-risk already populations, those with comorbid behavioral health conditions. You know, why are we not seeing full-blown resilience movements, you know, occurring within these populations? And in Ken's case, it sounds like a lot of those elements are going to be incorporated to the therapy that's occurring. You mentioned a variety of different modalities that you're offering, but also just, you know, strategically thinking through, could you design within your organization, Ken, a mechanism for very intentionally building those internal attributes, right? You've already created the environment. You've got that. But those internal attributes, you know, maybe doing an assessment of where you might be deficient in some of the resilience building strategies and intentionally building them in. It's the only thing I would add. I mean, it's very unusual to see the growth mindset right up front from a leader in your position and being open to absorbing everything that's coming in and filtering it through and then applying it in a way that makes sense for the population you're serving. So well positioned, and it would be neat, we've talked about this, for you to do a resilience movement within your organization. Thanks, Alan.
Thank you. And I want to thank everyone who generously donated their expertise and time for the panel today. And I intend to use the recording of this, which will be closed captioned, as a resource that I can share much more broadly. And I would make it available to you to share with others who may benefit from this integrated discussion, which is on the prevention side as well as on the care and treatment side, and the overarching constructs that Tom has brought to this. I feel fortunate because I stood in a place where I looked to the right and I saw my good friend of decades doing this noble work. I looked to the left, and I don't mean politically, but I look to the other side and I see Tom's work. And when I talked, it was through Tom, I got to know about Lora's work. And I thought, these are people who in this universe, they need to somehow be connected. And so I was just fortunate in that way. Also, I was fortunate to sit at the College of Public Affairs and have the Rosenberg chair. So Roger, if you want to say a word or two concluding, I'm grateful to use that as the mechanism for this, and I'll hand it back to you and then we'll wrap up.
Alan, thank you. Laura and Ken, what incredible presentations and what incredible contributions that you are making here. Thank you both. I really sincerely thank you both for taking the time to present today and be with us at the University of Baltimore. And Laura, I know you're part of it, but thank you both so much. Tom, I enjoyed your additional comments, your experience and wisdom in this area. And certainly your leadership shows very well, as Laura said earlier, what kind of resilience you have as a leader and how you've been able to provide to your team, and that's exemplary. Alan, thank you so much for organizing what has been a tremendous panel again. Kudos to you. And on behalf of our president, Kurt Schmoke, the University of Baltimore, and our college, I want to thank everyone for attending. And again, I can't end without saying the special thanks to the Rosenberg and Blaustein Foundation for the support that they've provided to make events like this possible. Thank you all and have a wonderful evening.
Thank you, Roger. And to everyone else, I'll be in touch with you individually afterwards in a few days.
Thank you.
Bye.